Welcome to the village. So today my guest co-host is Arshia. She's a pediatric palliative care physician. Thanks for being here.
Hi, thanks for inviting me.
Sure. So most people don't know what palliative care is or what it means, and they definitely don't know what pediatric is. So can you just explain to us the definition of palliative care medicine and what it is?
Sure. So you're right. A lot of people are not clear on the definition of palliative care, and oftentimes it actually gets confused with hospice care. There is definitely a distinction between the two, especially in pediatrics. So essentially, palliative care, how we describe it, is an extra layer of support that really takes care of a pediatric patient in a multidimensional fashion. We take care of pediatric patients with life-threatening illnesses, and essentially we take care of them from symptom management and also take care of their families while they're going through this difficult time through a interdisciplinary team. So our teams can consist of a child life specialist, a chaplain, a social worker, so we can really help address all of the issues that come along with having a life-threatening illness. And one of them is, of course, like I said, symptom management. But there's also the stress related to having this and the stress that happens in a family. Taking care of other siblings, taking care of parents, and having chaplains and social workers who can help address any psychological or social issues that they have.
As a pediatrician, I didn't even realize that difference myself. Like, palliative care is not like a hospice care. It's not necessarily end of life. It's just serious medical conditions too. So it's not necessarily a child who's received a diagnosis of something that's end of life, but it's also serious illnesses. And
right.
So I'll let you finish what you were saying.
Yeah, so like I said, with palliative care, we generally, as soon as they have this diagnosis, is an appropriate time to get us involved.
Oh, right away.
Right away. You don't have to wait until the patient is getting sicker or even has symptoms yet, but just knowing that this child is going to have a rough course, getting us involved early on is beneficial in many ways. One way is to just start getting to know the family and building a trusting relationship.
Yeah.
Another way is we can give them anticipatory guidance on what to expect along this rough course, with whether it's a cancer diagnosis or a patient who is a NICU grad or a patient who has, say, a mitochondrial illness, all these different types of serious illnesses.
Now, as you're talking, I'm thinking of patients in my own practice who probably could benefit from that. Like,
right.
I see NICU grads all the time, so for those that don't know what that is, that's when babies are born and they have to be in a neonatal intensive care unit, and they basically are born sick or born premature or born with some issue. They already have intensive care from birth until the time they're able to be discharged to their parents, sometimes to a facility. But the care that goes into then taking care of a complicated baby, that's what a NICU grad would be. And that's really more overall all-encompassing more than anybody would think.
Right. And you can follow the patient along from the time of diagnosis until either they're in a curative path or if they are going to go towards end of life. So I think more along the lines of a cancer diagnosis. There's some patients who will get cured, but they will have, again, a very difficult course with ups and downs. And so we can help with those patients. When a patient has a redirection of care and it's no longer a goal of cure but becomes a goal of comfort, that's a time when we can still continue to take care of the patients. And I just wanted to clarify again, the definition of hospice is when a patient has basically a prognosis of 6 months or less. That's when you can put them on hospice care. And the difference between that and palliative care is that they have more intensive end-of-life treatment and they can have home nursing come more frequently to visit them. Your direction is more of comfort.
Okay, so that's a huge branch of medicine that we don't think about much, especially in pediatric patients. Especially someone like me, I do general pediatrics. I go to deliveries and healthy babies, and it's like this great day, and people are taking pictures and posting. And when you think of baby, you think of our child, you think of this fresh new life, and you don't, overall, the majority of people don't think about sicknesses. I remember when I was a pediatric resident in the children's emergency room, the first thing you do when you see a patient is ask a history, and then you do your physical. And part of a history in an emergency room setting is asking the parents their child's illnesses or hospitalizations prior. That's just part of what we do. We don't know that patient in the emergency room, right? So we have to get to know them. And this one father was so irritated that he had to wait so long, and he had a 6-month-old there who was there for something. I don't remember what it was for, but I went in to ask my history, and I said, well, any hospitalization or illnesses? And he said to me, well, he's 6 months old. I said, and? Would you like to see our NICU or our PICU? Like that, you don't think that way, especially parents who are blessed with healthy children don't think this way. So to think of a child actually having a chronic illness that needs all these is such a crazy concept, but it's so true. I mean, this is what you do all day, every day, right? So what kind of illnesses are we talking about, or what kind of diseases? I mean, people have heard of childhood cancers, but what about other diseases would qualify for something like palliative care?
There's 4 main, really, I would say, buckets where you see children. So children who have a life-limiting illness but could be on a curative path, so that could be an organ transplant, or a child with cancer. Then you have children who have no real curative path, and that could be a child with cystic fibrosis. That could also be a child even with sickle cell disease. Then there's children who have neurological illnesses, so you can have kids with spinal muscular atrophy, or the final kind of bucket that I think about is kids who really are those neonatal diagnoses that are really not going to survive at all, and that's going to be your trisomy 18 or your trisomy 13.
Like they're born with some severe genetic disease that's really not compatible with like a long healthy life, that sort of thing.
Right. And in those scenarios, when you think about the definition of palliative care, you're not only taking care of the children, but you're also taking care of the families and the parents. So of course, you're not going to be able to do anything directly with a trisomy 13 or a trisomy 18, but what you can do is give the support these parents need to kind of have ways of coping with what they're about to see happen with their child.
Okay, so this, all in all, palliative care is like an all-inclusive family kind of support.
Yeah. And since we're talking kind of about which patients can get palliative care, and some of them being, trisomy 13 and 18 and children that you won't be able to directly interact with, the WHO's definition is taking care of a child's mind, body, spirit, and their families.
I actually read this on the Arnold Palmer Hospital for Children website that says, overall, attending to suffering caused by a life-threatening pediatric illness is one of the most intimate spaces for healing. It allows compassion to shine in life's dark spaces. Is that a nice kind of way of thinking
I think that's an
about it?
Incredible definition.
Yeah.
And that's how it feels, too.
Yeah.
It does feel like it's the most intimate moments of a family's experience, and it's a blessing that you get to be a part of that. Some families will make you feel like you are part of their family. And when I even kind of introduce palliative care to a family, oftentimes I will tell them, I am like the medical doctor in your family. I'm going to be the one who's going to be able to build those bridges between you and other parts of your care team, because you have such a large care team, and there's so many people who are going to come inside and outside of your room and going to give you all these different messages, and you may not remember everything that they're telling you because of everything that you're going through. I can either be at rounds with you and sit by you and walk alongside all of those rounds, or I can talk to your teams and help coordinate kind of their messages so that you can have a better summary of what's going on with your child, because it can be very overwhelming.
Yeah, to get a diagnosis for even a sick child, just to understand all of that. What are some of the reactions that you've seen from parents? Like, you've seen them when they first have this diagnosis, so you get to see them at the beginning. So any of these diagnoses, like, it's overwhelming because, like I said, everyone wants or expects this healthy baby and everything's great, but a lot of people don't have this. So how do parents react to this, and what are some of the struggles?
I've seen a large variation of reactions. I've seen everything from like acceptance off the bat and just seeing it as kind of God's will and wanting to just kind of work with the care teams. They're very like present from the beginning, very gracious. And I've seen some who have been extremely angry. Then of course like they come around later, but their initial reaction is that of, obviously understandable anger and disappointment. And some who feel guilt, some who feel
think it's their
just
fault
sadness.
somehow,
right.
or they did something.
Yeah.
Do you have a way, or do you personally, as the doctor, or like you said, there's an interdisciplinary team, so there's people there to help them through this, and how effective is this? Because in theory, you would think that all this support would make things easier. Is it effective? Do psychologists help? How do these parents then cope?
So our team,
how do the children cope?
Yeah, so our team has a chaplain and a psychologist for the parents and physicians, nurse practitioners, and our hospital has many child life specialists. So who the parent really forms a bond with will really determine and help how their course kind of goes. If they're not able to form a bond with anybody in the hospital, obviously it's going to go much harder. And then there are those who can form a bond with just a chaplain or just a social worker or just
options.
their bedside nurse.
Yeah, that's true. You never know who you're going to bond with personality-wise or who you connect with. So it could be any member of the team.
Right. And many times the children have connections more often with their bedside nurse or maybe their primary oncologist, but it's harder. Like the older children you'll be able to get along with a little bit better because they can ask those questions to the palliative care doctor or to their palliative care practitioner. But the younger ones are going to end up forming a bond with the people who can really sit and play with them. That's often the child life specialists.
Yeah, that's true. Now, this is a children's hospital type of specialty. What if there's patients like this out there? They may not have these resources because not everyone lives near a children's hospital, right? So what do you do in that scenario? And this isn't just for like the parents and the families. Like there's many pediatricians, like I didn't even know, for example, what the real definition was. And now I'm thinking of patients who might actually benefit from something like this. And yeah, we have our little ways and means in our hospital and in our office, but I feel like something like this, where I could have a palliative care specialist for some of these patients. How do we get more patients these resources?
So there's a couple of different answers to that. So the first thing I think about is brand new diagnoses that are these more acutely ill children, like with a new cancer diagnosis, or ones that are home on a ventilator or need that extra help. We have back in, I want to say it was 2016, concurrent care became approved, and that means children who are on a curative path can still also have palliative care or hospice care. So children don't have to be necessarily end of life to get in-home hospice care. So you can get them enrolled on a hospice who can come home and do cares for them and can do blood draws. And you're right, it's harder in more rural areas because they have less experience with children, but there's some that will work with you and will come home and provide that care. Now, they may not have the child life specialist and the social workers and all that are very familiar with pediatrics. So in that scenario, if they're connected to a children's hospital, looking into telemedicine might be something that be useful. So some palliative care programs have been exploring more and more and doing more research about what telemedicine would look like in that scenario.
Yeah, absolutely. I think especially with this pandemic, a lot of avenues with telemedicine were opened, which seemed like they would work for a lot of things anyway, despite the pandemic. So it's really good to know. Is this something that parents should think about or reach out to their primary doctor about, or should they look at websites on their own, or is this like somewhere in public health they should look into?
So I think to have palliative care or hospice care at home, your pediatrician should be able to facilitate that. And if they are unclear on how to do it, they can always reach out to the palliative care team that might be the local children's hospital.
Okay, so the nearest children's hospital would be able to help probably with that.
Right.
So first, going to their pediatric provider would be like the first step.
Yeah, and providing palliative care and not being a palliative care specialist every doctor should know how to do palliative care. Every doctor should know how to provide that extra layer of support and to be able to walk hand in hand and have a good ability to communicate and provide comfort to their patients and families.
So basically, it's not always so medical, right? So sometimes it's more of that social aspect, which I find too, like the more in depth I get with patients, the more I become, like you said, that part of the family, that social aspect, that professional who knows things, but also that knows how to just be there as a comfort. And it's not always about having medical answers, right? Sometimes it's about being a support and
validating feelings, being present. You don't always have to have an answer. Sometimes you can say, I'm so sorry that that's happening to you. Tell me more. Tell me more about what that means to you and your family. And just having that empathetic listening and therapeutic listening goes a really long way.
At our age, most people have had someone close to them pass away at this point. So when I look around and I see some of even friends, colleagues, anyone, the experience they've had with their dying family member, the way they feel about it for the rest of their life is impacted by the team. So having that person there at that time, or those people who made things a little smoother, it's like you can do it the hard way or the easy way. It's going to be done either way.
Right.
That's really important. And I'm just more curious about some more of this reaction. You know, especially as a general pediatrician, if a patient dies or has an illness, the entire office, we all know about it, becomes a huge thing. It's like a big deal because we're in community pediatrics. So us as the professionals have this reaction with families. Like, you know, some people out there listening to this may not have experienced this, but could in the future experience this for themselves or a loved one. So what do they do? Is there something you can tell people to do, or is it an individual reaction? I think that sense of loss or feeling lost is the big concern there. So just what should they do?
As far as how your office staff can cope, or are you talking about how to help
everybody.
the family cope?
So it's like we can go one by one. Like,
Yeah.
what would families do? Then what should the office staff do? And then I guess what can they do for each other? What should they do together? Just in a scenario with something like this happening, like what happens next?
So what happens next is a family should never feel deserted or abandoned after their child passes away. Definitely continuing to have a relationship with that family and reaching out to them ever so often and seeing how they're doing, I think, is always the right thing to do. And I know that's difficult for some professionals to do. They have a hard time with it because they have a hard time dealing with end of life and have a hard time watching
with that emotion. Yeah, that's hard for some professionals to do.
So having an inter-office debrief where you actually recognize it, name your emotions, and being able to discuss that loss as a team, I think is helpful. And in our hospital, we do that because sometimes we take care of patients for years and see them come in and out of the hospital, and you form bonds with them, and you have those couple of patients who just really live in your heart, and you have such a hard time when they pass away. So I know this happened to me just recently where we had a patient die, and like so many of us in the hospital, nurses, social workers, everyone is just, we are having a difficult time with it. And so we're
admitting that and speaking it out. Yeah, I guess a parent would appreciate that human emotion, right? For their child or their loved one, to know that a human being was there taking care of them. Like, it's nice to be the doctor, but
so they don't feel like just a number.
Yeah, exactly. And what should parents do if they don't feel that? Is there a way to change that? They have a feeling of disappointment, like my pediatrician wasn't involved, they didn't call me, they made this worse. Like, they should never feel that way. Most pediatricians are warm and fuzzy people, but some are not going to be. And how do you cope then with that disappointment that really shouldn't happen, but unfortunately it does? What would they do in that circumstance?
Yeah, that sounds really difficult. I don't know if I can tell a parent how to deal with it and how to cope with feeling abandoned by their pediatrician. But if they really felt like it's something their pediatrician needs to know, I think the office needs to be open for feedback, and that family should feel comfortable saying, when my child passed away, this is how I felt, and I didn't feel supported by your office. I feel like the office should be able to receive that and, make a positive change from it.
Yeah, that's true, because did they care? Did they not care? Did they not express it the right way? It's just figure out for the future.
I don't think that there's any pediatrician or any clinician who doesn't care. I think they all care. We all came into this for a reason. We all became pediatricians for a reason. And I think everyone copes in different ways and deals with in different ways. And I think we see this even in oncology or any other, field where every clinician kind of deals differently. Some of them go to the funeral, some of them don't. Some of them will write bereavement cards, some of them won't. It's not from a place of not caring. It's from a place of, everyone feels the loss and just, we're all humans. And so we all cope in different ways.
It's true. It's all personality types that go into pediatrics or in a different field. That is true. I mean, fortunately, in a community pediatric setting, we don't see it a lot, so maybe not even knowing what to do.
Right.
And that's why it's great to have our colleagues like Pediatric Palliative Care to kind of shine that light. It's really important to know, because it doesn't happen a lot, but it definitely happens. And to then be confused and lost as a provider is something that we can help and we can change. And then maybe as pediatricians, maybe reach out to each other and find a resource that does know. Like you said, every pediatric children's hospital should have some sort of a palliative care team, right? Or do they not necessarily all have one?
I don't think all have a robust team that have the bandwidth maybe to be able to do this, or may not even have a palliative care team. But I think intentionally having debriefs and reaching out to a resilience team, there might be someone in your hospital that is in charge of taking care of the resiliency part of your work. So there's social workers or something like that who can debrief with you. And it's interesting you brought that up, because as part of my job many times as a palliative care physician is to also palliate the teams, because they many times misinterpret or misread a family's reaction. One thing that I've been consulted for before is that a family is in denial about the diagnosis, and I say denial in quotes because a way a family sometimes copes with what is they're going through, maybe with a lot of hope. So they have realism, but there's also a lot of hope kind of intertwined with that, and it ends up looking like denial on the other end to a lot of clinicians, but in fact it's just their way of, coping with their situation.
That must be a real challenge for you and for palliative care specialists and the team in general, is understanding, because I had read your paper about the different cultural aspects of this, and I think that's a really huge issue in the world, obviously, that we deal with, that's been brought to light more and more, and dealing with specific issues in a child's life, whether it be the food they eat, the time they sleep, the place they sleep, how schooling works, the father's role, the mother's role, the grandmother's role. And there's something that we don't want to talk about, but you and me are talking about it today, is the death and dying or the very sick child. Culture has a huge role to play with this. So what are the challenges there, or some of the challenges, and what have you noticed with families, and I guess how should families think about this or deal with this? Because I think some families might think that they have to conform to some sort of norm with the hospital, or feel that added pressure, this is how I'm supposed to react. What have you noticed are the challenges, and what would you say to that?
Yeah, so that's a whole topic to itself, is culture.
Yeah, it's definitely a whole topic.
Yeah, so the place I like to start with is defining culture. So culture is, from a dictionary definition, is your language, your race, your ethnicity, and it's the dictionary definition of a culture. But truly what culture is every person has their individual and unique culture, which is really defined by not just your sex and your ethnicity, race, language, religion, but also your socioeconomic class, your education, your environment that you were brought up in. So I think what's really important for every clinician to understand is that culture is so unique to each individual. So if you try to think that you understand like Hispanic culture, if you try to think you've understood Islamic culture, Jewish culture, that is going to lead to a lot of biases and stereotyping, and then that's going to cause a lot of miscommunication.
I actually have, one of the episodes was about culture in peds, and basically what I had said there was you walk into a room and assume you know nothing.
Exactly,
Yeah.
100%. That is kind of my life's work, is to teach people to assume you know nothing about a family and to come in with a completely open mind. And so you might walk into the room where it's the grandparent who's the one who makes the decisions. You know, there are certain cultures where traditionally, you know, like Native American culture or even Indian culture or certain Middle Eastern cultures or Arab cultures, they will kind of communicate with the entire family and the community before coming back to you with a decision. But then again, like I said, each family is different, each culture is different. So recognizing that there are some families who might be like that, but then there might be some clashes within the family because their children, who might be the parents of the child, are more westernized and they may not want to follow those, you know, traditional values because they were born and raised in America.
Really dicey and really complex. And sometimes it's probably hard to gauge, is it culture and is it acceptable? Or is there really like some unhealthy behaviors going on in this family? Is this something that you can possibly intervene on?
Right.
And where is it then your place? I mean, that's a whole different topic. Like the doctor's place in intervening in unhealthy, that's my life's work, in unhealthy family dynamics. And what do I do? So that's something, I guess, since we're not focusing on that totally today, maybe another day, next time. But all in all, people should feel comfortable to voice their opinion and bring their culture with them,
right,
and what's comfortable with them, because it is about comfort, right?
Yeah.
You shouldn't have to deal with what somebody else thinks when you're trying to deal with this diagnosis.
Right. And our job is to come in with each room with curiosity and cultural humility. So the old kind of verbiage used to be cultural competency, but I think that trying to be competent in someone else's culture is basically impossible, and you shouldn't even try to do that. What you should try to do is have humility and ask open questions as to what makes them most comfortable, as far as how would you like to communicate and how do you like to receive information. Who do you like present at these, you know, really difficult conversations, and making sure those people are there. There's some cultures where they really want their pastor to be there or a religious leader to be there and be a part of their decision-making process. Or they may want their cousin who is not even here but wants to be called into every conversation.
Okay, and that's okay.
And that's all okay.
Yeah. And that's something you should respect.
Right. Right.
Oh,
so you're not going to know unless you ask, because you might just overwhelm this family if you just walk in and start throwing all this information at them and they don't know how to process it, or you're giving them the information they don't want to know and you haven't asked them.
Right, that's true. Overwhelming them, scaring them. And I guess it's okay to be scared and overwhelmed. You don't know who's going to react how.
Right. As an example, there was a family, and never underestimate the role of your interpreter. Interpreters are almost like cultural brokers. They're not only there to interpret for you, but they can also tell you about the culture of this family. And many people trust their interpreter even more than they trust the medical team. So there was one family where the physician would go in and just start blabbering about all, like, this is the prognosis, these are the labs today,
like
this is what's going on, like getting all sciencey. And they would do it in front of the child. Several times this would happen, and some of these families feel like, you know, from their culture, the doctor is always right. I don't want to interrupt them. I don't want to tell them what they're doing is, I'm not comfortable with it, or right. And then finally they told the interpreter, we don't like these conversations happening in front of our small child. We don't want him to lose hope, and we don't want them to talk about the labs and all of that stuff in front of the child. So basically, this doctor never asked the family, how do you want to receive information? Who do you want present? You know, very basic questions that will get you a lot, and you'll be able to build this beautiful, trusting relationship with the family.
Right. I think that's true. Like, you can really invest some time trying to understand these people as people, and it'll build trust and security and a really nice relationship for the duration of whatever this is.
Right. And speaking of trust, what I also wanted to bring up about palliative care is getting your palliative care team involved too late. That is also a huge bone of contention because, again, palliative care, like you had mentioned earlier, it's a very young field. It really only became recognized as a field in 2016.
Oh, I didn't realize that either.
Yeah, so
Okay.
all the fellowships across kind of the United States are still very young fellowships, and part of trying to get education out there, which this podcast is going to help with so much, is getting clinicians to understand what palliative care is and how to get us involved early on because it builds those trusting relationships. And oftentimes what happens is palliative care will come in too late. They'll come in like when there's no more curative treatments or options available, and this is the team that's going to help you with your end of life care. And so now we're being misinterpreted and
Yes, that's where the
being
confusion.
seen as someone who just takes care of the pain and symptom management and advanced care planning, just as somebody who comes at the end of life. And many times they'll get us involved and say, we're consulting you to go and get the post or the DNR and DNI. So again,
like end of life big things that like the difficult
and
conversations.
we've never had a relationship with this family.
So how do you talk about emergency situations with a family you don't know yet? So yeah, that's interesting. You brought up the training. That's a good point because people should understand when you have a palliative care team, the physician has done obviously medical school, 3 years of pediatric residency training, so they're trained pediatricians, and that you'll do a 3-year fellowship for palliative care, or
1-year fellowship for palliative care.
Okay.
And then many people are dually trained, so there'll be oncology in palliative care, ER in palliative care, ICU in palliative care. So you'll see that combination frequently.
Okay, so they just have that like extra ability and to like bring it full circle, and it takes a really empathetic person. It's really a blessing if you have a palliative care team, and it's not something these parents have to really look at like, oh God, why are these people in here? It's not a scary thing. It's a really good help because these are people that can help you to understand the disease, understand the diagnosis, give you as much help and support as you need. I have to say, some of my patients who have a hard diagnosis, like prematurity, and now they have cerebral palsy, or they have developmental delays from that, or I have some patients with Down syndrome, sickle cell disease, cystic fibrosis. They could probably use this, and to me, I send them to this specialist or that specialist, and we try to get them help through the county has Department of Public Health, and they're able to help with therapies and this and that, and it always feels like there's something missing, like I'm not doing for them, and the parents are so strong and they're trying their best, but they waded through a whole system where now they are strong, but they're also tired. I don't know what all their emotions are, and this seems like somewhat like just picturing like an angel coming through. Like, I'm here to help you. Like it seems like something so necessary, and so this is really good for not just the pediatricians to look into further, but for parents to understand that there's more help out there in this way. So if you don't have this, look for it, ask for it. Is that what you would suggest too?
Yeah, and if they're seeing all these specialists, especially having a palliative care, sometimes the specialist will say, oh, we don't want another person complicated in the mix. But the palliative care physician, the great thing about what we provide is that we'll tell them, if you have a full day and you don't feel like coming to our appointment, don't come. We'll just talk to you over the phone.
This is for you.
Yeah.
You guys are completely there for the family and the child.
Yeah.
And I'm sure you have your own special relationships with the actual patient too, because I always tell my patients too, even like the healthy ones who just want to talk about something unrelated without their parents, you're my patient. The family is really important and they're crucial, especially for something like this, but when it comes down to it, the patient is the child. It's their name on the chart. They're the ones with the issue. Patient. And whether they're 1 or, 21, they're the patient. Is there anything else that we should know about pediatric palliative care at this time, or any message you want to give us?
So I guess just to summarize, the pediatric palliative care team is there as an extra layer of support. They're there just to help a family from beginning to the end of a very life-changing, life-threatening illness that affects the entire family. Everything from the parents to the grandparents to the other children. Being able to provide that support can happen in any really way. We can do it on telemedicine, we can do it on the phone, we can do it in in-person clinic visits. So we try to be as flexible as possible to just provide the best care possible and find community-based supports. And another thing that's part of our team that I didn't mention is having, and this will be a part of a hospice team as well, as having a bereavement specialist. So we don't leave you even if your child leaves you. We are there by your side.
That's so awesome. Well, thanks so much. This was really excellent information. It's so great to just hear about all these resources and all this information because children are so important, and it's great to know that it truly does take a village. So
It does.
yeah, thanks so much for being here.
Thank you for inviting me. This has been great, and I'm happy to come again.
Awesome.